So with all your permission, dear doctors, we are getting started. So may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as digital partner for this event, jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation USA chapter. The focus of today's session is echocardiography in assessment of shock. Well, to start with today's Sunday TE session, I would like to present before you a short inauguratory video.
Good morning and welcome to the Sunday breakfast session dealing with echocardiography. Thank you so much for joining us. This event is being conducted under the auspices of the Karnataka chapter of IACTA, the Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiologists, Global Heart Care Foundation, Global University of Cardiac Sciences, and the International Society for Cardiac Ultrasound. And today we are very fortunate to have two eminent faculty from the nation, Dr. Harish Mallappa and Dr. Vivek Kumar. Dr. Harish Mallappa is from Bangalore. Vivek is from Mumbai. We are indeed thankful to them for joining us because they are leaders in this subject, and we are looking forward to their deliberations. So before I actually invite Dr. Vivek Kumar to take over, I would like to request the participants and faculty present here to pose their questions and comments in the chat box, which we will respond to at the end of the talk. Till that time, keep your audio and video muted, closed, I mean to say, and we look forward to this session. Dr. Vivek Kumar is a leading critical care specialist from Mumbai. I have great pleasure to introduce him as the moderator. And Dr. Vivek Kumar, please take over and do the carry on with the session. Thank you
Thank
so much.
you, Dr. Muralidhar, sir. It's always a great pleasure to interact in this forum. And it's also my great pleasure to welcome Dr. Harish, whom I've known for many years. and who's the Director of Critical Care Services at Kaveri Hospital. But I think that's a very small brick in his big wall of illustrious academic career, and he has brought so many young intensivists into the fold of critical care in the correct way. So Harish is going to speak on a topic which I really love, and that is echocardiography in the assessment of shock. And I request all the participants to be interactive. Please post whatever queries, doubts, or questions you have so that we can have a meaningful interaction. Over to you, Harish.
Thanks, Dr. Vivek. So thank you. Good morning, all. So maybe in another 25 to 30 minutes, we'll take you through an overview on the utility of this echocardiography in assessment of shock. I'm not going to touch in respect to in depth of each protocol what we have, but we'll give a practical knowledge with a backup of its clinical utility. So how we can use echo for the assessment of shock in critical care unit and in the emergency department. So like we know that like in the last three and a half decade, echo become like most commonly used gadget for shock assessment, hemodynamic monitoring and all. So nowadays it's not like we will find any of the say tertiary care unit without echocardiography in their unit and all. So it become a basic. It's like a clinical examination. So it should be learned by all the practitioners, whether you are practicing in ER, anesthesia, or maybe in and around ICU, like pulmonologists, physicians, particularly critical care specialists and all. So when we define a shock, so we know that shock is a multisystemic end organ hypoperfusion. So it doesn't mean just a low blood pressure is going to be tagged as a shock. So shock can happen with a normal blood pressure or maybe low or high blood pressure. So mandatory criteria for defining shock is there should be some sort of cellular dysauxia. So with increase in some sort of the markers of the shock, maybe lactate, poor peripheral circulation, capillary refill time is like altered. So postural hypotension, mottling. So basically it's the end organ, multisystemic end organ hypoperfusion, not just a drop in blood pressure and all. So initially we have something called like three windows of the shock. So decrease in urine output, okay, skin temperature and altered mentation. So these things, like if you wait to assess the shock as the ultimate clinical manifestation and all, so then it's going to take too much of time. So by the time you are going to tag anyone who is having a urine output low, so some sort of irreversible damage has been happened to kidneys and all. So we need some sort of dynamic assessment. So we can't just rely on the clinical markers of shock. We need to assess like hemodynamic monitoring in a dynamic way. So for that, definitely echo is going to be one of the like clinical utility at the bedside and all. When you see the types of shock, so in ICU, remember, I'll just take a pause here.
Yeah, we can see the slides.
Sir, you are muted once again.
Dr. Harish, you are muted, I guess.
Yeah, can you hear me? So I just switched on the AP. It's like I thought weather is cold. So
Okay.
basically in ICU, will not get a straightforward case. Okay, so it's a well-defined hypovolemic shock or maybe cardiogenic shock kind of this one. We have a mixed pathophysiology. Say, assume patient was a known case of coronary artery disease with a compromised contractility with EF of say around 20-30% and all. He presented with severe community acquired pneumonia, so sepsis, septic shock. So you can have a like component of both the cardiogenic and that of the septic, that is distributive shock, with that of the hypovolemia ongoing and all. So you will not get a clear cut, okay, this is the only entity we are going to tackle. So, but broadly, we can have like low flow state. So where we are going to have the low volume hypovolemia. So cardiogenic shock, obstructive shock. So basically in cardiogenic shock and obstructive shock, so even though there is a effective systemic circulation is there, but the problem is it is not coming out of the heart to perfuse the tissues and all. So like with the background of volume status adequate, but it is not able to come out. So overall, we categorize them for understanding as a low flow state in terms of the shock. When it comes to like distributive shock, that is most commonly we have this septic shock or anaphylactic shock, so which we categorize as a hyperkinetic shock. So here there is a relative like hypovolemia will be there. So there is a peripheral vasodilatation will be there. So like systemic vascular resistance is going to be low. So that we categorize as a distributive shock. So the features of each of 4 types of shock often overlap, and patients admitted with one type can develop other type of the shock and all. So it's not like, okay, you will have a straightforward single entity of the shock. So if you go through this, okay, so when patient is having some signs and symptoms of hypoperfusion, as I already told, either it may be altered mentation, so skin mottling or cold temperature at the peripheries and all, decrease in urine output. So we are going to assess there some sort of the other signs, like whether patient is having tachycardia, so biochemistry like elevated lactate and all. So then we are going to categorize. So if you have bedside central venous pressure, okay, so we can utilize, so not for like getting an idea about the fluid responsiveness and all. So but you can utilize if the CVP is very low. So it tells, okay, probably most commonly the cause for the low CVP is going to be low volume status and all. But if the CVP is high, so are we able to get an idea, okay, it is because of any other entity of the shock? So like it's very difficult to make it out, because even patients with say normal volume status also can have the high CVP and all. So but it gives some clue. So you search in and around cardiogenic shock or obstructive shock, or it may be a volume overload kind of this one. So again, like if the patient is having a low CVP with a fairly maintained cardiac output and all those things, it may be a distributive shock and all. But if you see, the most common type of shock in an intensive care unit is going to be septic shock, which contribute about 60%. So next comes like we have hypovolemic shock, cardiogenic shock. So then like a small entity of like obstructive shock and all. So distributive shock, which is other than the septic shock, is contributing about 4% in the intensive care unit and all. So next question, if we narrow down our discussion in the background of, okay, what is going to happen to shock? So different entities of the shock. So broadly, how we can utilize clinical signs and symptoms. So are we really having a good suggestion or good guidelines, okay, on the utility of the shock in means on the utility of the echocardiography in shock? If you see, so lots of data is available. So we suggest that when further hemodynamic assessment is needed, echo is the preferred modality to initially evaluate the type of shock as opposed to more invasive technology. And also basically echo is being extrapolated from the emergency room into the intensive care unit. So like when a patient came, so whether it's a fast examination, trauma, or whatever it may be, so then we used to put the echo probe to get an idea about whether the heart is contributing to shock or something else we need to search kind of this one. So that is being extrapolated to ICU, and lots of data is there. So lots of suggestion, lots of recommendation are there on the utility of the echocardiography in intensive care unit and all. Okay. So if you go through any of these protocols, okay, it's a never ending name game. So like ultrasound protocols, we have FATE, FEEL, BLEEP, okay, goal directed limited echo, goal oriented handled echo, clue, raise, focus, beat, rush, ED, rush, blue protocol and all. So basically here, any of the protocol, so you are going to adopt at the bedside. So how you are going to choose? So by doing that, so what additional data we are going to get, okay, so how it is going to be user friendly. So what is its sensitivity and specificity in terms of not missing a patient who is having a shock, and we can narrow down the diagnosis or etiology. So what is the cause for the shock and all. So basically, like it's not some sort of, all the protocols have been very well validated, and it's going to have a like advantage. We don't have something called very ideal protocol kind of this one. So but follow some protocol, because so if you adopt any sort of these kind of protocols and all, so there's a less chance you are going to miss any etiopathogenesis for the shock and all. But you have to keep your mind open with a lots of differential diagnosis taken into consideration of their clinical profile, okay, and your clinical examination biochemistry with the background of echocardiography and all. We'll try to understand couple of echo modalities in assessment of the shock. So this is called focus assessed transthoracic echo, that is FATE. So basically we are going to get an idea about the subcostal four-chamber view, apical four-chamber view, okay. So then parasternal long axis, parasternal short axis. So then in addition to that, we are going to have the pleural scanning. So to get an idea about whether patient is having any pleural effusion, particularly in a trauma patient is having any hemothorax and all. So pericardial effusion, okay, so dilated RA-RV, so dilated LA-LV. So along with that, like if patient is having some sort of pleural space collection, we can narrow down whether it is the hemothorax which is contributing, that is a hemorrhagic shock, or patient is having a cardiac tamponade, okay, so that is obstructive shock, or patient is having a dilated RARV, so which is again one more cause for the obstructive shock, that is the pulmonary embolism. So in that way, we can get fairly a good knowledge if you fit into something called focus assessed transthoracic echocardiography and also. This is how we can like go through the different windows of long axis, short axis, subcostal view, and that of the identification of the pleura. So with subcostal IVC, we can assess. So in terms of getting an idea, so in a non-spontaneously breathing patient, okay, we can give some weightage. So not a single value of the IVC, but we need to tag that IVC variability with that of the respiration and all. So then only we can get an idea, okay, so something is bothering kind of this one. So if you just see an IVC, like, okay, so IVC diameter is this much, it doesn't tell anything. It's like a measuring a CVP and all. So we need to tag that IVC variability with that of the respiration. So then only it tells, okay, so having some sort of like hypovolemia where, so that IVC collapsibility, IVC distensibility index values are going to be get exaggerated and all. So next, as I told, so this echo has been extrapolated and moved from the ER. To begin with, we were having something called fast in trauma. So basically utilization of the like focused ultrasound examination for the trauma patient and all. Here again, some modification later they done. So they added E-fast to get an idea about like pleural space and all. So in the subcostal space, so basically we are going to get an idea about the pericardial tamponade. So IVC in the subcostal, so right upper quadrant, so perihepatic collection, okay. So then in the left upper quadrant, we are going to get an idea about perisplenic collection. So in patients with the blunt trauma abdomen, it's very, very important to get an idea. So when patient is having some sort of collection with the background of unstable hemodynamics, so then you have to be having some idea. You are dealing something which is very, very important to address on immediate basis and all. So if patient is having a small collection with the stable hemodynamics, we can wait and watch. If patient is having a collection in any of this space, like hepatic or perisplenic with the unstable hemodynamics, so there is something significant which is bothering. Along with that, we can get a pelvic area in and around the bladder also. So this is like E-fast examination. So basically quick enough, so we can repeat in the ER, okay. But some subjective component will be there when you do echocardiography. You need little bit of expertise. So only thing is it is non-invasive, repeatable, okay. So but the problem is subjectivity and minimal basic training you require to do the E-fast in trauma patient and all. So then one more protocol we have, that is rush ED examination. See, basically, as I already told, so if we add too many of the windows, too many of the parameters which we can try to observe, so that become one more protocol kind of this one. So what they done here, so parasternal long axis view, so apical four chamber view, okay. So IVC Morrison's pouch, okay, to get an idea about the hemothorax, splenorenal pouch with that of the hemothorax, like pleural space assessment, bladder view, so aortic slide, pulmonary view, means all these things together they put it is as the rush ED examination and all. So but I like this protocol, at least it narrow down some sort of differential diagnosis and all. So basically you are going to get an idea about the heart, IVC, Morrison's pouch, that is perihepatic space, aorta, pulmonary window and all those things, okay. If patient is having a pericardial effusion, so with RARV diastolic collapse, so RARV is collapsing, so then we are going to narrow down our diagnosis with that of the cardiac tamponade. So remember, so in a patient who is going to have a severe hypovolemia, so they can have something called pseudo tamponade kind of this one. So it doesn't mean, so you need to tag it as a cardiac tamponade. So there should be fairly adequately filled system. So with that RA-RV dilatation, with the patient is having a pericardial effusion, so during diastolic collapse, so then we can tag them as a pericardial like tamponade and all. So remember, so basically, like for that, when you do an echocardiography, you need to attach the ECG leads and all. So many of the echo machines, they have a ECG attachment facility and all to get an idea. So definitely it is having a diastolic collapse. So suppose patient right ventricular dysfunction, we are having RV, which is going to be more than that of the LV. So we can narrow down towards the diagnosis of obstructive shock. It should be acute. It's not like, okay, chronically their RV is hypertrophied and it is some sort of like pushing the like interventricular septum towards the LV. That should not be the scenario. If it is an acute RV dilatation, so then we can narrow down towards the obstructive shock. Remember, patient can have pulmonary hypertension, but it may not be pressure which is beyond 55-60 of the pulmonary artery pressure and all, because RV is a thin musculature. It's a triangular in shape. So in acute pulmonary embolism, okay, it will not get a time to hypertrophy and to generate the pressure in a significant way. So if RV is like dilated, so with the pressures which are not crossing more than 50-55, it is an acute scenario. If RV is dilated with hypertrophy and the pressure generated in terms of pulmonary hypertension, which is 60-70 and all, so then you need to think it may not be a like acute thing, it may be a subacute to chronic like carpulmonale and all. So basically this rush ED protocol give an idea about the another like cause for the obstructive shock, that is going to be pulmonary embolism. So then tension pneumothorax, we are going to have an idea about the absence of lung sliding and lung point. So remember, just an absent lung sliding is not a confirmatory test for the pulmonary, means like tension pneumothorax and all, because so many patients with fibrotic lung, interstitial lung disease, severe ARDS, okay, so they also don't have the lung slide and all. So when we have a lung point, so it is a junction between so-called seashore and the barcode sign. Okay, so that is the confirmatory thing for the like tension pneumothorax and all. So then we move on to left ventricular dysfunction. So if a IVC is plethoric, okay, so then we can have an idea with a background of poor contractility and eyeballing of the LV. So even though you are not going to calculate, okay, what exactly is the ejection fraction and all, but we can see something, okay, LV is good, so our LV is bad. So LV is like supra physiological, hyperdynamic kind of this one, okay. With that background, if IVC is dilated, so we can give an value, okay, it looks like a cardiogenic shock and all. So then if patient is having some sort of LV fairly contracting, but so IVC is collapsing, so we can have some idea. So it looks like volume depleted state and all. So then if patient is having a normal contractility of the LV or maybe hyperdynamic contractility, hyperkinetic contractility, so then we need to narrow down. So if the patient is having some sort of distributive shock, okay, like sepsis, anaphylaxis, or some sort of the toxin induced and all, or it may be hypovolemic shock. So if you assess the EFAST, some criteria and all, if there is any internal hemorrhage, so then we can narrow down. So it looks like a background of hypovolemia, it is because of the hemorrhagic shock and all. So basically this gives an idea fairly, so narrow downing into differential diagnosis of our shock etiology and all. So one more thing we got, okay, so instead of, okay, we are not able to get an idea about so your cardiac output and all, so they taken into surrogacy of this, so velocity time integral, so VTI. So they try to categorize based on a particular cutoff value of the VTI into hypovolemic, cardiogenic, obstructive, or distributive shock and all. So that they tagged it as rush VTI protocol. So basically, so there are some papers, we know that with their limitations and all, so they used changes in the VTI, okay, before giving the volume or after giving the volume. So if the VTI has been increased by 10 to 15% from that of the baseline, they tagged them, okay, they are volume responsive and all. But the problem is, okay, it is again a subjectivity. You should not move the probe. So positioning, okay, so errors, angle change. So lots of things can happen when you depend upon so aortic VTI to get an idea about the fluid responsiveness and all. So as I told, so each modality, each protocol is going to have some limitation. So then this is the blue protocol. So bedside lung ultrasound examination. So here to get an idea about one of the cause for the shock, we are going to get so ruled out this pneumothorax and all. So otherwise, so we are going to get an idea about the consolidation, pneumonia, okay, or if patient is having multiple B lines like pulmonary edema, so which is basically cardiac origin. So if you get a multiple B lines with a background of poor contractility, IVC is plethoric. Okay, so then we can narrow down is having a bit of pulmonary edema, which looks like cardiac origin and all. So if the contractility is good, okay, so then if patient is having some sort of multiple B lines and all, so then it may be simply because of pneumonia also, or maybe ARDS or pneumonitis also. So it's not like, okay, just patient is having multiple B lines, we are going to narrow down it always to cardiogenic pulmonary edema and all. So as I already told, if patient is having a normal A profile, okay, with a lung point, so it's not just the absence of lung slide which is going to be confirmatory for pneumothorax. So lung point should be there. So then we can narrow down our diagnosis to pneumothorax. So this is one more protocol, that is the blue protocol and all. So as I already told, so it's a never-ending game. So name game. So this is the comprehensive way we can understand what additional parameters which we get from different protocols and all. Okay, if you go in depth, okay, each of the protocol validation, comparison, so lots of limitations we are going to find. So I'm not going to put all those things, but so fairly you adhere to some protocol with the background of biochemistry, with the background of clinical assessment and all. So this is the comprehensive table where they like put all together what additional data. So in terms of these parameters we get in each of the protocol and all. So as I already told, so rush ED is something which we can look into getting a differential diagnosis when it comes to like getting an idea about the what is the etiology for shock and all. So how to evaluate in daily practice. So we learned, so basically what exactly is the shock, different types of shock, a basic pathogenesis of the shock and all, different protocols which are available with the utility of the echo for getting an idea about the etiology of the shock and all. But at the bedside, how you are going to use it. So as I already told, in terms of the shock, we have cardiogenic, hypovolemic, obstructive, and distributive shock. So cardiogenic, primarily we have a massive MI, so severe anterior MI, or it may be sometimes sepsis-induced cardiomyopathy, but it is going to be reversible. Okay, so it's going to have some sort of dilated global hypokinesemia. So in terms of the septic cardiomyopathy and all. So sometimes we have valvular pathology or maybe severe diastolic dysfunction, myocarditis. All these things are some of the causes for the cardiogenic shock and all. So as I already told, as an intensivist, we are not bothered about, so say ejection fraction of 36 versus 38 and all. So we are not bothered. So if there is a gross variation in terms of the contractility, so idea is, so is the heart is the culprit for shock or not? So whether heart is very badly over contractile or it is under contractile or it is normal. So that we call it as an eyeballing. So that is more than enough. Quickly we can get an idea, okay, heart is the culprit or not, kind of this one. So are you interested to get an idea about the cardiac output? So remember, so in critically ill patient, there is nothing called normal cardiac output in shock patients and all. Okay, so it's always a relative phenomenon. So assume patient is having a cardiac output of 2.5. So then if organs are perfusing well, means his urine output is good, his lactate is downtrending or maybe normal, his peripheries are warm, no postural hypertension. Okay, so then his capillary refill time is like less than 3 seconds and all. We are not bothered about what cardiac output he is having, kind of this one. So it is always a relative phenomenon. That's why, so we will not give much value to single value of the cardiac output and all. So we want the changes in cardiac output, changes in the stroke volume, means before and after. So before giving fluid, what was the baseline, or before doing some PLR, so what was the stroke volume, whether it is increased after doing the PLR by about 10% or more than that. So then we can tag them. So they are having a volume responsive and all, than giving a weightage to single value of the cardiac output and all. So suppose you are interested to calculate the cardiac output, so we can go for apical 5-chamber where we can get the VTI, and in the parasternal long axis view, so we can get the aortic root diameter and all. So pi d square divided by 4. So that tells about your stroke volume. So if you multiply the stroke volume with that of the cardiac, means heart rate, then you are going to get the cardiac output and all. So may not be required always. So to get cardiac output, one value at the bedside, kind of this one, it is okay to get an systolic function of the heart. Means as I already told, okay, eyeballing is reasonable accurate with experience. So you need some minimal experience, may not be required to calculate the particular number of the ejection fraction or maybe contractility, means like cardiac output and all. A little bit on the like regional wall motion abnormality. See, basically, so when you have a patient, typically with a chest pain, okay, so with some sort of ECG changes, so it is better to get an idea, narrow down, so which territory is involved. So basic training is also required to get an idea, so what is exactly the regional wall motion abnormality. So that needs some training, but we can get an idea which vessel territory has been involved, so in terms of causative for the myocardial infarction and all. So one more entity in ICU, okay, there is something called Takotsubo cardiomyopathy. So here apical ballooning will be there. So we call it as a broken heart syndrome, octopus heart. So assume you are dealing with a neuro ICU where patient is having a severe subarachnoid hemorrhage. Okay, so they can have a sympathetic drive like anything. So they can have this entity. If you done cardiac enzymes, they are going to have a positive for cardiac enzyme, no doubt. If you done a ECG will have all STT changes which fit into myocardial infarction and all. But if you done an angio, so you will get a normal blood vessels. Okay, so normal coronary. So that we call it the Takotsubo cardiomyopathy. It is going to be reversible once pathophysiology of the SAH or traumatic brain has been like under control. Basically, it is an extreme of sympathetic drive, so which caused apical ballooning, that we call it as a Takotsubo cardiomyopathy. Always take into the context of what exactly like clinical background patient presented to ICU and all. So bit on RV infarct. So remember, when we are doing an echocardiography, if patient is having a inferior wall MI, so if there is an isolated RV involvement is there, okay, so then you will get pulmonary oligemia. Means like, see, in MI, if patient is having acute LV dysfunction or cardiogenic shock, obviously we are going to have a back pressure, so B lines and pulmonary edema and all. But RV isolated infarct, pulmonary oligemia will be there. Whether you do an X-ray or maybe lung ultrasound, so there are no much of the B lines and all. If you have a patient with a PA catheter, so then their pulmonary artery occlusion pressure is going to be normal or maybe bit low if it is an isolated RV infection. So basically pulmonary oligemia with like PA catheter is showing some sort of normal or low pulmonary artery occlusion pressure. So narrow down your diagnosis towards that of the RV infarct, because see, there is some specific things. So age-old teaching, okay, like don't give diuretics in RV infarction, you can give fluid. But remember, you can give a fluid in a guarded way, because if you too much overload without any echo guidance and all, so interventricular septum is going to bulge towards the LV. Okay, even though patient is having an isolated RV infarction, so because of interventricular interdependency, it's going to compromise the LV intake. So obviously, overall, it's going to reduce the cardiac output and worsen the shock and all. So it's not like too much volume overloading. Guarded judicial volume we can give, and we can avoid diuretics when you diagnose RV infarction and all. Okay. So next, hypovolemic shock. As I already told, if you just use IVC or you see the LV and all, if LV is kissing, so first thought process, differential diagnosis we can have, okay, it looks like an hypovolemia unless otherwise proven and all. So, but if patient is not having any of these criteria and all, so then we need some sort of other dynamic assessment and all. So remember, when you do an echocardiography, so it doesn't mean patient is volume depleted. Okay, you done an echocardiography, so IVC is collapsing, LV is kissing, RV is collapsing. Okay, it doesn't mean they always respond to whatever the volume you are going to give. So basically, preload, so that is the end diastolic volume deficit, does not mean they are going to be fluid responsive always. So if you give an volume externally, if it is not coming out, so then as per the Frank Starling like curve, so if the end diastolic like volume is low and you are giving the external volume, if it is not increasing the stroke volume, so it's going to put up the back pressure, it's going to increase the pressure exponentially. So preload is not equivalent to that of the preload responsiveness. So if you done an echo, it doesn't mean, so all these things like narrow down to hypovolemia and you give volume, so it may not always come out. So that we call it as a wasted preload also. Okay, so where we can put echocardiography in a patient who is unstable hemodynamically. So as I already told, if he is having some sort of low CVP, okay, so with its limitation, or IVC is collapsing, LV is kissing and all, so then we can tell hypovolemia is more likely. But if this is absent, then comes the $1,000,000 question. So we can utilize the echocardiography, rule out other causes for the like the volume status or unstable hemodynamics like obstructive or maybe other primary cause from that of the heart and all. So how much value to give for IVC. Don't get passionated with, okay, I'll see IVC and all. So lots of limitations. So we can do transthoracic echo to get an idea about the something called, so IVC, delta IVC distensibility index with a particular cutoff value and all. So remember, when patient is in spontaneous breathing, we are going to calculate something called IVC collapsibility index. But so there is no control on his respiratory drive. When patient is tachypneic, so obviously IVC can collapse badly. It may false positively tell. So patient looks like volume responsive. That's why to be very careful in a spontaneously breathing patient to get an idea about the IVC collapsibility index with a cutoff value of more than 50%. So distensibility index, those patients who are under controlled ventilation, so then we can have a cutoff value of more than 12%. They look like, probably they look like volume responsive and all. So this is something which we published long back. So suppose in a post-surgical patient where we are not able to get a IVC window in a subcostal way, so we can use like something called transhepatic window to get an idea about like IVC with some sort of the good correlation with the subcostal or subxiphoid value of the IVC variability in a patient who is having some sort of volume depletion and all. So again, this is what I spoken. So if you consider the accumulation of the recent data which happened in terms of IVC diameter for getting an idea about the fluid responsiveness, so it is not like very good modality. If you see, this is one of the systematic review and meta-analysis, lots of data is available. In extreme heterogeneity of included studies was highlighted. So ultrasound evaluation of diameter of the IVC and its respiratory variation, so does not seem to be a reliable method to predict the volume responsiveness and all. See, it is just an extension of a CVP. Okay, so just don't rely on IVC collapsibility, particularly in a spontaneously breathing. So getting an idea about the volume responsiveness and all. Okay, so that is the take home here. So SVC by using echocardiography, difficult to get a window. We need some sort of experience. But if you have a TEE, then we can use. But transthoracic, very difficult. But the data suggest so good like specificity when it comes to using so SVC collapsibility with a cutoff value of 36 degree, means 36 percentage in terms of the predictiveness of the volume responsiveness and all. So then move on to next entity, that is obstructive shock. So see, this is the patient with sudden onset of breathlessness. So elderly, 65 years, this is the ECG. So if you done the lung point, this is what I told. So there should be a junction between the what we see as the barcode and that of the seashore sign. So that is the confirmatory test towards that of the echo finding of like say pneumothorax and all. So then you can have the like X-ray, but if you put a like a vascular probe on your anterior chest wall, when you get lung point with the background of breathing difficulty, unstable hemodynamics, so then you are narrow downing your diagnosis as a obstructive shock, that is because of the tension pneumothorax and all. Okay, so again, like shortness of breath in a middle-aged lady, so hypotensive, if you see RV is dilated here. So remember, in like pulmonary embolism, most common ECG finding is going to be sinus tachycardia. So you will not find S1Q3 T3 pattern hardly in about 8 to 10% of the patients you can get. It is very, very difficult to find. But sinus tachycardia, so ABGY is a respiratory alkalosis. If you put a echo, it shows acute RARV dilatation. So then you can narrow down diagnosis toward the obstructive shock. That is because of the pulmonary embolism and all. So like there is something called eccentricity index. You can get an idea about the RV to LV ratio. If that is going to be more than 1, so then it move towards narrow down towards the diagnosis of the pulmonary embolism and all. See, normally when you see the apex of the heart, it is going to be formed from that of the LV. If RV is forming the apex and RV is overhanging that of the LV, okay, so then something acutely bothering. So it looks like pulmonary embolism and all. Okay, so basically we can confirm. So if patient is not having a shock, so then we can move the patient for CTPA. But if patient is having shock with the background of RARV dilatation acutely, if that shock is not explained by anything, so then you can consider thrombolizing that patient if you exclude any contraindications and all. So then tricuspid annulus peak systolic excursion TAPSE. So normal value, if you put an M mode, okay, so it should be more than 1.8 centimeters. Then it gives an idea about the like prognostic indicator in terms of the RV dysfunction secondary to PE. So if it is going to be 1 to 1.8, so moderate dysfunction. So severe if it is less than 1 centimeter, that also we can get an idea from that of the echocardiography and all. So McConnell sign, okay, again, you will not find in many of the patients. Don't get preoccupied. You will see this right ventricular free wall hypokinesia in echo in the presence of normal RV apical contractility. Okay, its positive predictive value is hardly 40 to 50%. So as I told, S1Q3, T3 and McConnell sign and all, you might not get in all the patients that of the pulmonary embolism. So these are the echo findings which we discussed till now. So as I told, if you see the pulmonary artery pressure, so it's going to be usually less than 55, 60 and all. It is not exponentially high. If it is high, then you should think the pathology is going to be subacute to chronic. It may not be acute PE and all. So this is again the cardiac tamponade in terms of like obstructive shock etiology. So RARV means diastolic collapse. Okay, so plethoric IVC. So then like mitral valve inflow variation is going to be more than 25%. So then we can narrow down our diagnosis with the like collection of the fluid in the pericardial space. So it looks like cardiac tamponade and all. So lastly, distributed shock, that is a septic shock, is the most common thing. So this is how echo-based algorithm we can do in septic shock and all. If patient is having hypotension with signs and symptoms of inadequate perfusion, so screen for the pre-existing cardiac disease. Means if you have an history, okay, we have to be very careful. So that might be contributing, or it is worsened with the background of sepsis also. Then, so see for the LV-RV contractility, means eyeballing. So like low contractility, low cardiac index, so then we can start them on inotropes. So RV failure, then we can consider to give some sort of like fluids also. So then if patient is having a low cardiac index, so with normal RV and LV function, so then if they are having severe hypovolemia, so preload responsiveness, we need to ask that question. If answer is yes, so then we can consider to give some sort of the volume and all. So basically this is an overview on the utility of the echocardiography even in septic shock also. So you see for their contractility by eyeballing, taken into consideration of their volume status, then get an idea whether they are going to volume responsive or not. Okay, so to conclude, echo is the most single useful tool in the diagnosis and management of the shock. So hyperdynamic LV is highly specific for sepsis. So bedside echo better over the static measurements in sepsis, means like particularly you can't rely on CVP or one value of the IVC and all. So LVOT VTI is a useful surrogate marker for LV stroke volume, but its limitations and all. So dynamic serial assessment is the key for the proper management. So but the problem is like we need some sort of training. Okay, so it is a non-continuous, not like okay advanced hemodynamic gadgets, so we can get a continuous value and all. So echo like transthoracic, it cannot be a continuous, and there are lots of inter-observer variation will also be there. So this is again an echo algorithm in shock. Okay, in patients with background of unstable hemodynamics and all. So if they are having a pulmonary congestion, so quick targeted echo, so like particularly start with subcostal and apical view. So if they are having moderate pericardial effusion, compressed RARV, collapsed IVC, assume tamponade. Okay, so severely enlarged akinetic RV, assume pulmonary embolism. Severe hypokinetic LV, assume acute pump failure because of the myocardial infarction or maybe myocarditis. So if patient is having a small hyperdynamic heart, collapsed IV, so assume severe hypovolemia or maybe hemorrhagic shock or septic shock. Here see assume. So remember, you need again the clinical profile, other diagnostic investigation modalities to confirmately tell, okay, this is the cause for the shock and all. So taken into consideration of all these things, then you need to give value to the echo findings and all. Thank you.
Thank you, Dr. Harish. That was a wonderful disposition, and it was going back to a lot of in-depth analysis into why and you should do a echo and how it works. So I will just summarize in my way. The first thing is please do a clinical examination, have a clinical diagnosis before you take the probe. Echo improves outcomes in undifferentiated shock. That should be very clear. It is a dynamic modality. It needs to be repeated. If patient is hypovolemic, you give fluids, please repeat the echo. If you feel it's an obstructive shock, you're lysing, please repeat the echo and be fast. Fast in the sense you really have to be tuned up. That is why so many protocols are there. But now at this stage, I just say look at the heart, look at the lungs, look at the abdomen, and if you still can't find an answer, look at the aorta, look at the femorals. So which order you scan is as per your clinical differential. That is one. It's highly operator dependent. You need to be trained. Please do any of the workshops which we conduct. You really need to be trained. It cannot go to the floor, because then your diagnosis will also go out of the window. It has to be opened up in the long axis. Most of the algorithms today are based around the assessment of LVOT, VTI, as Harish pointed out, because that is a surrogate for stroke volume. And after whatever therapeutic intervention you do, please have a real look at it. Okay. And then, of course, with good eyeballing, you should make out this is a empty RV, this is a empty LV, this is a bloated RV, this is a bloated LV, this is a squeezed RV, this is a squeezed LV, or this is only a squeezed LV and the RV looks big. So, and the last thing is, if the patient is in shock and the heart is beating fast, hyperdynamic, either the patient is hypovolemic or the patient is vasodilated. Read more and you will know how to differentiate. So I open the forum for questions. There is one question in the chat box. If the patient is in shock, do you recommend cardiac ultrasound in emergent examination? As per what Dr. Harish has shown, it is very clear. You first do your standard clinical stuff, and if there is no initial response, you go in for a echo, or if you think it's a undifferentiated shock, you go in for a echo. But if you know it's a obvious GI bleed and the patient is come in hemorrhagic shock, you don't start with the echo. Yeah, Harish.
That is correct. Yeah. So that is very clear. See, young patient without any comorbidities, assume came with diabetic ketoacidosis. Young patient without any comorbidities came with diagnosis fairly maiden as severe acute pancreatitis. Okay, young patient who came with pouring out like 10, 12 episodes of loose motion with metabolic acidosis, lactate high, pre-renal component of the EK and all. So do you require like echo to get an idea, okay, this is some sort of hypovolemia? Answer is no. Okay, so there again comes the resuscitation. So don't think, okay, I need an echo, see the contractility, and again give volume of 300 ml, then see for the volume responsiveness. That should not be. Okay, so basically you have fairly 90%, 80% an idea on the basis of clinical presentation, okay, on basis of your clinical examination. So patient is having a shock, which type of shock? So then doesn't mean you waste time in, so no, sir, I learned like how to do volume responsiveness. We'll give 350, 400 ml of volume, then we'll do PLR, again see cardiac output or VTI. That should not be. So you are in a doubt. So I don't know what kind of shock is there. Okay. So like assume the same young patient who came with pain abdomen, so like some sort of documented severe acute pancreatitis, but he was a referred case from somewhere else. He was already there for 12 hours, 18 hours, 24 hours. So he received some initial part of resuscitation. Then you are the receiver. Then you have to be like careful. Okay, the same 150 ml per hour of the fluid need to be continued, or you need to assess its volume status. So you need to take into consideration of the clinical context always with the background of echocardiography.
Any more questions?
There is one question on the chat box. Hello.
Answered, sir.
Answered.
That
sir.
is answered, sir.
Yeah.
Answered. Okay,
Yeah.
okay. And that is a lovely presentation. Well done. Anybody wants to comment? We have some experts in the
So can I come in?
group. Yes.
Please feel free.
We have about 12 minutes to go.
So can I come in?
Yeah, please.
Yes. Who is speaking?
So this is Dr. Moderator.
Yeah. Please feel free. Yes.
So just it was excellent presentation. I think as Dr. Harish rightly pointed out, there are a lot of protocols. Of it, the help of the American Society of Echocardiography guidelines in September, I think, 2024, wherein the terminology for the cardiac focus has been streamlined. So we have now, I think, basic and advanced focus when it's the treating physician who's doing the echo to rule out any emergency situations. That is one. Second is, I have a question for Dr. Harish actually. Regarding many times we get confused in ICUs when the patient comes in with RV infarction, and we are really not able to rule out pulmonary embolism. There again, we have a severely dilated RV with, LV involvement as well, D-shaped septum, and all those things. Is there any way in echo we can really rule out pulmonary embolism based on this situation?
So if you have a both acute dilatation of RA-RV, okay, so then if patient is in shock, then like your RV is overhanging, that move towards more of your PE as compared to that of the RV infarct and all. So again, with the background of ECG findings, we can get some idea, okay, so is RV abnormality, whatever we are getting on echo, whether it is an infarct related or it is a PE related kind of this one. So very rarely, okay, if patient is having like some sort of significant thrombus, like we can make an attempt to visualize the thrombus also, but it may not be always possible. So, but as you already means like clearly told, so sometimes it is very difficult to get an idea, okay, so RV abnormality is isolated because of the RV infarct, or it is because of, say, acute pulmonary embolism and all. There comes also again some sort of your like clinical profile, risk stratification for PE, okay, all those things we can taken into consideration to narrow down the diagnosis. Or like RARV dilatation is there, unstable hemodynamics is there, without any like some sort of known coronary artery disease or risk profile and all. So then we can assume that as a contributing factor because of the PE, and you can proceed in a sick deteriorating patient for the thrombolysis also. So that helps anyhow for your infarct also, means if he's in the window period for thrombolizing even cardiac related infarct kind of this one.
Thank you so much. Thank you.
I'll just add on to that. So what, as Harish said, first there's the clinical profile. You can do your wells for DVT, wells for PE, or you can do the SPECI. The second is the ECG. Generally, we don't have isolated RVMI. That's normally seen in the setting of inferior, posterior. Very rarely patients will come in with the isolated RVMI. Then after the ECG, when you look at the echo, so it is better to image the RV. So one is we can see it in the focused apical 4-chamber view, and then from the plaques you can make the RA-RV outflow inflow view, and then you can also see it in the RVOT in the short axis view at aortic valve level. So generally, I mean, if it is a MI only, you will just have a they will have a hypokinesia of one of the RV walls. So the RV wall can be seen in the apical 4-chamber view, in the RV inflow view, and in the RVOT in the short axis view. So you see all the walls, you will find only one wall is hypokinetic, and there is a RWMA. Vis-a-vis, when you look at pulmonary embolism, there will be hypokinesis, but there will be compensatory apical hyperkinesis. You really have to look for that. And obviously, you can look at the MPA and try to find the clots in the IVC or in the main pulmonary artery or the branch pulmonary arteries. So there is a full table in literature on how to differentiate between a RVMI and this. But basically, you have to do all the RV views in that case.
Yeah. So
I would
definitely,
like
Vivek, yeah, you need a next level of training for that to get an idea about an isolated one sort of part of the RV got infarcted, or it's a global thing which looks like an PE kind of this one. So some extensive, thorough, different views of the echo you need to do for that.
Thank you.
I would like to add that if you can see a clot in the PA using the short axis ascending aortic view when you're doing TE, That's a definitive indication that it is a pulmonary embolism, but rarely you find clot in the PA. Most often it's already traversed and caused pulmonary embolism, so you may not find that sign. And also, if you do the D dimer, if the absence of the elevation of D dimer is rules out pulmonary embolism.
Yeah,
Do you
that is,
agree with that?
yeah,
Do you
yeah.
agree with that, Harish?
But yes, sir, the problem is definitely it gives a negative predictive value. But
Yes, yes.
say,
That's
assume like patient is having a acute RV infarct or maybe PE. So in both scenario, we can get the D dimer. If it is absent, so then we can have a fairly okay. So with a good negative predictive value and all. If it is present, even in a critically ill patient,
present. It
yeah,
doesn't.
yeah,
I mean, for pinpoint that it's pulmonary
yeah,
embolism.
yeah.
No,
Hello.
but I think whenever there is a thrombus
Please.
formation, there will be some increase in both fibrin and fibrinogen degradation as well.
D dimer will
So
be
D
elevated in both.
dimers are going elevated.
Yeah.
Hello.
Yes, yes,
Yes,
Can I comment?
yes, yes, yes,
So,
yes, please.
Manjula Sarkar. So
Yes.
basically, that selection of the patient is very, very important. In which patient the 2D echo is going to help in the critical care unit. And for the beginners, that apart from the selection of the patient, they should know that limitations of the 2D echo, that in each and every case, it is not going to be helpful. So these 2 points has to be taken into consideration before taking 2D echo help.
Thank you, ma'am.
Yes.
Dr. Sanjeevani, you wanted to say
Yes, yes,
something?
yes.
Thank you, Dr. Manjula. Thank you.
Yeah.
Harish, it was an extensive and really, it has given a path to juniors as well as to us. Just wanted to ask, can this TROP-T would help us in differentiating um, uh,
No, even
embolism and infarct?
no, even in PE also, see, we have something called dysfunction and injury in pulmonary embolism. So when patient is having a pulmonary embolism, if there is an injury, they can kick off their troponin and BNP. So that is one criteria where we put them as an intermediate category of the PE and all. So
CPKMB.
no, again, very non-specific. See, any muscle injury, even both can kick off kind of this one. So very non-specific. When it comes to markers, even like if they have any stretch in the myocardium, so BNP can be raised. So even though, yeah, means like both PE and RV infarct, so stretch is there. See, basically they need just a stretch to increase BNP or some sort of myocyte death to give rise to troponin and all. So may not be helpful in differentiating this scenario.
Ma'am, as the RV afterload increases, na, the RV wall stress increases.
Yes.
And as the RV myocardial wall stress increases, the RV circulation is compromised. So in a way, it produces RV ischemia infarction, and that is why the troponins go up. And then because of the stretch, because RV stretches, because of the increased afterload, the BNPs go up. So that is actually now used, as Harish pointed out, to stratify them after the diagnosis
Intermediate.
into intermediate high and intermediate low risk.
Yeah.
Okay, another point that RV infarct alone is very, very rare, isn't it? It is always or usually associated with RC territories like inferior septum, inferior wall. So would that help us in guiding that yes, it could be RV infarct, because if we see inferior wall and inferior septum also hypokinetic. RV's lone infarct is very rare because RC is affected. So
Yeah.
naturally these two walls in LV also would show some
It
See,
should,
ma'am,
yes, madam.
I'll just cut Harish short. So, both acute embolism and acute myocardial infarction are time-dependent processes. So we do the bedside assessment, and if it is more in favor of P, we take the patient for CTPA. And I think there we can decide, there are hospitals and there are protocols where if they do the CTPA, it is negative. Sometimes they can do the CT coronary angio if you have a low probability. But I think the thing is, whichever way you decide, you rush the patient for either CT coronary angio or CT pulmonary angio, and you will get the diagnosis there. Because beyond this, we cannot waste time. Actually, if you look at the recommendations, no guidelines recommend the use of echo in the diagnosis of pulmonary embolism. That's it. Low probability, D dimers, anything intermediate and high, go for a CTPA. It's only as intensivists we have configured that you look at what is the cause of shock and all, but the cardiology guidelines do not recommend. So we don't waste time. We rush the patient for CTPA if we think it's a venous embolism.
Yeah, pulmonary embolism, in acute pulmonary embolism, the echo findings are indirect evidences. It's not a direct evidence in most of the circumstances.
And there, just a last comment, see, echo in PE, the sensitivity specificity increases as the patient worsened hemodynamically. Means, so if there is a compromised caliber of his right ventricular outflow is going to be compromised more than, say, 50%, 60% and all, then he is going to have a significant unstable hemodynamics. Then he is going to have the back pressure effects and all. So it is always related to his instability. So where our echo findings prediction, picking up value is going to be increased and all. I think one more question is there. Last, I think.
Yeah, last one you can
I've
answer, and then
that.
we have to.
Yeah.
The answer is the lesser time you waste is better.
Yeah.
If the patient is in shock, you really have to differentiate between, say, obstructive or a cardiogenic shock, and that is it. And be fast.
Yeah.
So, so that is why all these protocols are there, so that you go sequentially, you don't miss anything. So, Dr. Murli sir, I'm through. The time is up. It's over.
Thank you so much. I really appreciate both of you for having taken us through this complex subject of echocardiography in shock conditions. Thank you so much. Very well done. I would like to thank both Harish and Vivek for their presence and taking us through this topic. And now I will request Ritu to show a couple of slides, and it is a short video. I don't know whether she's able to show it. After that, we'll close, and thank you so much for joining us. And I would like to make an announcement that next Sunday and the next Sunday, that is 8th and 15th, we'll not be having the Sunday breakfast sessions in view of the TE workshop at Medanta next week. And 13th, 14th, 15th, we have our own critical care echocardiography workshop at Narayana, Bangalore. Because of this, we will not be having Sunday TE breakfast session on 8th Sunday and 15th Sunday of this month. Thank you so much for joining us, and over to Rituparna, please.
Thank you, sir. So, sir, any conclusive remarks from your side, sir?
Thank you all.
Thank you so much.
Thank you. So, with all your permission, dear doctors, we are ending over here.